Well, good afternoon or good morning, depending on what part of the nation that you're in this morning or this afternoon. But glad that everyone could be with us today. Welcome to the Facility Compliance Think Tank presented by Soleran. My name is Mike Foley, the Vice President of Strategy of Business and Development here at Soleran. I'm going to be your moderator on today's webinar. This is our third webinar in our three-part series, Navigating the New Normal. In today's topic, it really is timely, projected regulatory compliance changes, a regulatory update. Now, our webinars have really two purposes. One is to discuss best practices in the areas of facilities, life safety, emergency preparedness, security, and other compliance-related topics. But the other side of it, it really is all about the community. It's about coming together, connecting, networking. The webinar was really created to help healthcare professionals network together and share ideas. So when we get to the Q&A portion of the webinar, don't hesitate to ask any questions that you may have. With that said, let me go ahead and introduce our panelists for today's webinar. First, I'm going to start with Lance Woolf. Lance is the Director of Life Safety Compliance here at Soleran. He's a former Life Safety Code Surveyor for Joint Commission. He has 17 years experience in hospitals at the director and senior director level. During that time, he oversaw engineering, emergency preparedness, safety, biomed, security, and environmental services. Next, we have Billy Kinch. He's a facility specialist surveyor at CIHQ. He's been with CIHQ, or the Center for Improvement of Healthcare Quality, for 7 years. He developed CIHQ certificate program called Healthcare Accreditation Certified Professionals in the Physical Environment. It's also referred to as HACP-PE. Billy has over 20 years experience in healthcare. He also served as the safety officer and disaster preparedness coordinator in hospitals prior to coming to CIHQ. He's got a master's degree in healthcare administration from the University of Phoenix and a bachelor's degree in education from Wayland Baptist University. And finally, we have Clint Butts. He's the Standards Application and Interpretation Specialist for DNV. He's been with DNV for 7 years. He spent 2 years as the Virginia Department of Fire Programs Fire Marshal. He was a physical environment life safety surveyor at DNV for 2.5 years, but he also served as a code and regulatory compliance consultant. He has spent 11 years as environmental health and life safety specialist at Swedish Memorial Center, 13 years as hazardous waste manager at the University of Virginia, and 9 years as an EMTC with Charlottesville Albemarle Rescue Squad. He's got a bachelor's degree from Southern Illinois University. With that said, I just want to thank and show appreciation for all of our speakers taking time out of their very, very busy schedules to join us today and provide their deep-rooted expertise on this topic. It should be a fantastic hour of learning for everyone here, including myself. So with that said, just a couple of housekeeping items. So really the flow of today, each panelist is going to have roughly 10 or 15 minutes using PowerPoint slides. But just know this webinar is meant to be tremendous value to you. So, take screenshots if you want to. You can take copious notes if you want to do that as well, but know that the link is going to be provided to you at the end of the webinar for you to go back and view at your leisure. So if you just want to just choose and sit back and just soak in the material today, that's fantastic. You can do that as well. So after our speakers have presented for 10 minutes, we're going to have a live Q&A session at the end. Please use the Q&A button at the bottom of your screen to ask questions. So if the toolbar disappears, just scroll your mouse over it, it will reappear for you. One of the last slides in the presentation, we will have FCTT's web address on it, so you can utilize the site to help network in the future. And in the future, as well as get in touch with Soleran after the presentation, we just encourage you to reach out to the FCTT web address and get connected there. So let's get started with the webinar. As a former Joint Commission surveyor, we've asked Lance to kick it off by offering his insights and his perspectives of the upcoming regulatory changes. Lance, take it away.
Thanks, Mike. I appreciate the introduction. And today we're going to go ahead and talk about some regulatory compliance changes, and this is going to be specifically related to Joint Commission. So we'll go ahead and start. So next slide, please. So let's start and talk about document review. One of the changes that's recently occurred with document review for this year is document review used to be 90 minutes total to complete. That's now increased from 120 to 150. With that increase, they've done away with the environment of care session during the survey process. And so now they've allotted more time during document review, and now your life safety code surveyor is going to hit ambulatory areas as well, where prior, that was a clinical person. So some recommendations with that is, one, make sure your documentation is organized. If it is organized, you're going to have less findings, and it's going to set the tone for the survey from that point on. And one of the other suggestions is keep your surveyor, keep them, moving forwards with the standards. So just, as you're working with your documentation, follow the standards, keep moving forwards, and and make sure you keep that documentation in your room being used for review. For example, when I was surveying, I had situations where individuals were very unorganized with their books. And so while they were out looking for the book for the next section that I was focusing on, I was still looking at the book that I just looked at. And there were times where there was some oversight, and I recognized that there was another finding just because I had more time looking at the book and going through some more documentation while I was waiting. So also another recommendation they have, if you are electronic, have 2 or more people familiar with those documents on site during survey. And the reason why that is a suggestion is I did have an incident where we had an individual that was trying to go through the electronic and focusing on, looking at the reports, and he was very unfamiliar with it, and actually got to the point where he stood up and had me take it over. So I actually started going through the information and identified other findings where that wouldn't have happened if another individual would have been there that would have been familiar with the documents. And the last recommendation I have is don't focus on your IOUs. You want to keep the surveyor moving forward, and you want to keep focused on the documentation as you're going down through the list. So and the reason why is you have plenty of time, I wouldn't say plenty of time, but you still have time until the end of that survey to get those IOUs. So to get with your vendor, be able to ask them for the information that's needed. So don't focus on IOUs. Don't spend time trying to search around for that, because also too, you're only allotted so much time. Next slide, please. So let's talk about some new areas of focus for 2022. One is going to be the building management program. And even though this was voluntary, the building management program portion of the life safety chapter has been removed. So you no longer have to have a building management program. I know many of us had it and been worked on it annually every year. And so they've taken that away completely. So that's no longer needed. Let's talk about sprinkler heads. This comes under LSO 20135 EP7. And what it says is at least 6 sprinkler heads for each type and temperature rating installed in the facility are available, along with the associated wrench or tool to replace a sprinkler head. Now with that, you've got to keep in mind, you need to identify how many sprinkler heads you have, because there's a graph to follow. And so based upon that graph, you're going to need that many sprinkler heads, in your cabinets. To make sure that you're meeting that guideline. And also keep in mind, spare sprinkler heads in the wrench are stored in a cabinet location that does not exceed 100 degrees Fahrenheit. So if it's in a hot room, you're going to want to make sure that you take that temperature, make sure it doesn't exceed that. Also another area of focus, and this is effective immediately, is with egress and suite designated areas. And surveyors have been lax over this over the past few years, and at times, hospitals have started taking advantage of this, moving equipment into those areas, and their reasoning when they walk through, oh, this is a suite, this is a suite. So surveyors, just kind of overlooked it and walked through the suite areas real quickly, and then started focusing back out on the survey on the other areas. But because that was being taken advantage of so much, now effectively, immediately hospitals and critical access hospitals now are going to be surveyed for the 36 minimum egress and suite designated areas. And this comes under LSO 20120 EP42. This is also a new standard that's coming up. Next slide, please. So let's talk about your fire pumps. This one comes under EC 020501 EP5, and this is not specifically identified as an NFP requirement with the EPs. Where this comes under is the maintenance of the fire pump. So look at your rope packing. the surveyor is going to go in and they're going to be checking them to determine the drip rate. And so you're wanting a drip rate of 1 per second. If you're above that, it's not being maintained properly, or if it's completely dry, which there have been situations where I've seen that, and that tells me right off the bat that the rope packing is not being checked and not being maintained, per manufacturer specifications. Also, the BBI. Surveyors are going to take a closer look at your square footage. They started surveying to this year and ensure that it's correct and current. And where this is coming from is, when they did away with the BBI and the RFIs and everything, the BBI started being overlooked, throughout many years, and so quality started entering the square footage, and at times that square footage was incorrect. And so what was happening with Joint Commission is they were having too many surveyors show up or not enough surveyors show up, and that created a problem for the facility. So there happened so many times, Joint Commission came back out and said, no, we're going to start looking at the BBI. We're going to ensure you have the correct square footage, and if you don't, that will be a finding. So let's talk about sealed batteries. Sealed batteries, they're starting to focus on conductance testing, and this, you do your weekly voltage, but they're also looking at monthly as well. So not only are you going to have conductance testing that's going to be looked at monthly, and this is already occurring. One of the clients that we work with, I just spoke with them last week. They had their survey, and the surveyor specifically asked them about doing conductance testing monthly. And for many of you know, it's just a tool where you go up, it shows you red, yellow, green, and that your batteries are good. But they're also going to have further scrutiny in those areas to see if your batteries are truly sealed or capped. If they're capped and they're not sealed and maintenance free, keep in mind you need an eye wash station within 10 seconds or 55 feet, and that has to be uninterrupted. You can't go through a door. Also, let's talk about lead acid, and this can be vented or flooded. You need to make sure you're doing your weekly electrolyte testing or voltage monthly testing, which includes specific gravity. And then that's the same thing with nickel cadmium, is you're going to have your weekly checks of your voltage levels as well. Next slide, please. So another area of focus, this is coming up right now, and in the past, areas like supply chain management and CT, your radiology areas, they kind of weren't really worried when surveys were going up, because your surveyor would walk in, he would look around for dosimeters, he would check your MRI extinguishers to make sure it's non-ferrous, and then that was basically it. Boom, they were gone out of the area. Well, now that's going to change, and specifically your clinical surveyors now are going to start to look at EC 02, 04, 03. So they're going to look at your CT and your topography. So they're going to start looking at your physicist reports. They're going to start pulling that, making sure it's being done annually. They're also going to be looking for staff that has dosimeters, and they're going to be also looking at to make sure you're meeting manufacturer's specifications, or with your physicist report, if anything's identified, they're going to want to see that you closed the loop and fixed any issues. Another area, and many of you already know this, is coming up with the water management plan, and this comes under EC 020500, and this is going to be a whole new standard. And with this, it's going to require a team. So no longer now do you just have your engineer and your infection control on there. You have to have a specific team, based upon the size of your organization, and you also identify too how big you want your team to be. But there are specific people that need to be on there. If you have any other questions with that in regards to the team, you can contact me after this webinar. I'll be more than happy to give you all the information on who specifically needs to be on that team. But it for sure has to be your water management group. Has to be a representative from there. It has to be director of engineering. It has to be infection control. It has to be emergency preparedness on your team. Now, granted, that could be the same person for multiple of those roles, but you're going to want to identify that in the future on who's going to be there. Also, your water management diagram is going to expand, and the reason why it's going to expand is because the water management program now goes to any MOBs that are served by the hospital as well. So anything in the MOB area, which is dead legs, stagnant water, you're going to have to come up with a plan on how to approach those dead leg issues in those areas and go through and identify those areas. Another area that Joint Commission is currently working on right now, and this will probably come out, or this will come out in 2022, is how do you monitor it? What are the monitoring protocols, specifically the PEL limits? So they're identifying that right now. That information will come out next year. Also, new equipment added. Another area that are going to be focused is if you add new equipment, what are you doing to test the water management or test the system to make sure that you're reducing Legionella within your roofs. Anything that also goes with construction, that's pretty common. We already know that. Any changes within your loops, you make sure that you're testing the system and reducing Legionella, and also you're testing to make sure that there's nothing present. Next slide, please. So let's talk about stored energy supplied systems. This is going to be more focused on your larger units in your information technology areas, IT. So you're going to want to get with your IT and make sure that they're doing testing, and it's mainly the monthly testing on it and on the battery output information. So you're going to want to look at your subsys units, make sure that they're monitored, make sure the screen's there, and make sure that they're testing it monthly, because that's going to be an area that they're going to start focusing on. Let's talk about emergency management. The first one is going to be no surprise to anybody. Your focus is going to be on COVID and triage setup. Also with future building designs, they're already talking about that right now on what they're going to do in the future in regards to how to respond to future pandemics. After SARS, after H1N1, now with COVID, there's a pattern that keeps occurring. So you're going to see that focus now from emergency management that, in the past is focused on decon, more geographical locations. It's going to be COVID based now as well. Also, you're going to have a focus on supplies and an increase in supplies. I can use state of California, for example. State of California just passed a law based upon the hospital size is they're wanting a 90-day PAR level on site. So we're no longer talking a small room, we're talking warehouses based upon the size of your facility. So keep that in mind. California is already doing it. That's going to be a new focus with Joint Commission coming out with the new emergency management standards in 2022. And that's going to be an area that is going to change in regards to increasing the PAR levels. Also changes within HVAC systems to change air pressures. One of the questions that I'm getting right now currently is if you have changed your HVAC system, how is Joint Commission surveying doing it? Well, they come out and they clarify that and said it's based upon your policy. The only thing that they say when they come in and they survey, they look at it and make sure you're following your policy. If not, that'll be a finding. But the only thing that they additionally added was when you change that area back, you need to come back in, you need to make sure it's certified, air balanced, and ready, back to go with the original design. The next part, I already talked about the EC session. It's no longer part of the survey process, but you're going to see emergency management and infection control sessions are going to start meshing together. So you're going to have more people there. And specifically, not only is it just going to be your life safety surveyor, it's going to be your clinician is going to be involved in your EM sessions as well. And this it comes if your life safety code surveyor's days are 3 or more. So if it's three or less or 2 days, you won't have that clinician there. So if you're a larger facility, then expect that. Also, workplace violence is going to become more of a focus during leadership session. This will be, chances are you will not be involved in the leadership session, but keep in mind that many of the director of engineering, you oversee security. So that's the area you're going to be involved with, specifically with workplace violence, and there'll be new standards coming out there. Also, cybersecurity, that's going to be a whole new standard coming out in emergency management. They're still identifying those specific areas that they're going to focus on, but they expect that to come out with the new emergency management standards in 2022. Next slide, please. Let's talk about elevator door coverings by vinyl wraps. With our marketing groups, they like to come in, they like to cover our elevator doors and put information. They just like to change it to where they make the elevator doors look, cosmetically better, how they consider it. One thing that's happening right now is Joint Commission is starting to survey to the vinyl wraps, and specifically that they're UL rated. So elevator doors, they're fire rated, so your vinyl wraps have to be UL 10B rated. And so make sure they're not just certified for UL 723, because that only applies to the standard test method for surface burning. So that's basically the lighter test. It's based upon the flame spread index and the smoke developed index. So that's required for an interior finish. That's like a 10,000 level, overview on that on 723, where specifically UL 10B is the same rating as a fire door. So if you have vinyl wraps, make sure that they are 10B rated. If they're not, you're going to have to remove them, or it'll be a finding. Next slide, please. Well, that's all I have today. And if you have any questions, I'll be more than happy to answer them at the end of the session or in the future. All right, thanks, Mike.
That's Hey, fantastic, Lance. I appreciate you being on today, and that was great insight from the Joint Commission perspective of all these upcoming changes. Now we're going to turn our attention to our next speaker, Billy, to talk about survey updates with CIHQ. Glad to have you here, Billy.
Thanks, Mike. I appreciate it. Well, welcome everybody to this webinar, and I'm looking forward to working with everybody. Next slide, please. All right, so just a little bit about CIHQ. I'm sure there's going to be people on this that have never heard about us, but just wanted to give a little bit of an introduction. We are the newest accrediting body of the 4 that have deeming authority for acute care hospitals. You have Joint Commission, DNV, HFAP, and then now us, CIHQ. CIHQ actually opened in 1999. We started out as a consulting service. Throughout this time, we felt it necessary at the time to look for the possibility of becoming a deeming authority. And so we did go through that process, and we did receive that deeming authority from CMS in 2013. Since then, we now have a total of 130 hospitals that we accredit. Of those 130, 114 of those are through deeming status. We do also accredit some freestanding emergency centers and what are called CLIFs, which is a congregate healthcare living facility. And so between those two, we have about 40 hospitals. So that's just a little bit about us. And so we can go on to the next slide, please. So just some updates from the field. Some of you may have heard and have experienced in the past some validation surveys. So kind of how the validation surveys worked in the past is organizations would have their accrediting organization that would come and do their surveys. And then within 45 days, sometimes hospitals would get validation surveys where they would have another team of state surveyors that would show up and they would go and do their own survey. And so what happened, and the reason and rationale behind these, is that in order for your accrediting organizations to maintain their deeming status, they had to get inspected from the state and from CMS to assure that we were continuing to survey to the CMS conditions of participation. And this is how they did that. And so what they would do is they would take the 2 reports together from your accrediting organization and also from CMS, and they would look at those and would come up with a disparity rate, which is any time that CMS found a condition level finding in their report and your accrediting organization never had a finding in that at all, irregardless of whether or not it was a condition level finding, then there was a disparity. And so that's what accrediting organizations are surveyed on. So more and more discussion was going on that this process seemed more cumbersome on the hospital, which it was. For those of us that have actually experienced a validation survey, it was very cumbersome on the hospitals, but it was looking at the hospitals as opposed to the accrediting organizations, which is what the validation process was supposed to be. So a couple of years ago, we did start a pilot program where CMS was going to follow and mirror your accrediting organization. So if you had 5 surveyors from your accrediting organization, you would then have an additional 5 surveyors from CMS, but it wasn't like you had 10 surveyors. The 5 surveyors from CMS would just be looking at the surveyors from your accrediting organization. And so what they would do is they wouldn't participate in the survey. They were there just to observe. And so we were going through the pilot process, and then COVID hit, and that kind of shut down everything. So in talking with CMS, we're not quite sure when the pilot process is going to start back up, but sometime in the future, and there still has not been official word as to when this will start back up, but the validation process will start back up, but under the old way and not the new way. Hopefully we can get that back underway. So just wanted to give you that quick update. From CIHQ standpoints, we're going to talk a little bit about the top findings, just so you are aware as well, if you've never looked at our standards. Our standards are very closely aligned with the CMS standards. So if you were to look at the CMS conditions of participation and then look at our standards, you're going to see a very big correlation between. So we set our standards up exactly as the COPs are written, and then also the interpretive guidelines as well. So we all ultimately have to meet the CMS regulations. So that's why we set our standards up. that way. So just like Lance was talking earlier, documentation sets the tone of your survey. So still always are having findings related to documentation. I think it's a good job or a good idea to even include your vendors during a survey process, to have them come in and see exactly what do your surveyors look at during these surveys. So they need to understand, especially if they don't have a big background in doing inspections for hospitals, if they're just used to going out in your local businesses and doing those inspections. The documentation that we look at is scrutinized a little bit more than what you would in the normal business areas. So still looking at that, one of the main biggest issues that we are seeing is an inventory of assets and showing a pass-fail of those devices. And then if you do have a failure, being able to show a corrective action and then a retest of those devices to make sure that they were completed. So that seems to be the biggest issues that we're seeing. Then also from a frequency standpoint in areas like that. Next one's going to be around your GFCIs or ground fault circuit interrupters. If you look in the CMS conditions of participation, you're going to see a requirement that all equipment is tested per manufacturer's instructions. And so when you look at GFCIs, you're going to see that the manufacturer of these devices require organizations to conduct monthly tests of these devices. So that's what we're going to hold organizations to. A lot of times we do get some pushback on this, mainly related to the requirements out of NFPA 99, which talks about hospital grade receptacles and patient bed locations. Keep in mind that the additional testing, even when it's talked about in NFPA 99, talks about additional testing is based upon performance data. NFPA 99 goes on to indicate that performance data is defined as number one, what the manufacturer may require, and then two, if the manufacturer is silent, then it's going to be on additional information that you may get from your own internal resources and then also other hospitals as well, as far as failure rates, things like that. But most importantly, it's always going to go back to the manufacturer, and that's going to be the prime example or the prime tool that we're going to go back and look at as well. Keep in mind that it is per manufacturers, or you may also utilize an AEM or an alternate equipment maintenance program if you deem it safe and necessary to place those GFCIs on one of those programs. But then keep in mind that you have to follow all of the requirements for an AEM program. The next thing we're seeing a lot more frequently are related to wet system gauges, your sprinkler gauges. There's a requirement that you do a monthly visual inspection of those gauges to ensure that they are in proper working condition and that their proper pressure is in place. So a lot of times we just see, yes, we're doing those, but again, just like everything else, we need an inventory list of those and documentation to show that we're doing that. And then also related to those gauges, they are required to be replaced every 5 years. So as we do the building tour, we're going to go around and look, and a lot of times the year is stamped on those gauges. So we'll take a look at those gauges and see if they have a date greater than 5 years, and if they are, that's typically when organizations will have a finding. I know Lance also talked about your sprinkler inventory. We had the same requirements that you heard earlier. One of the things that we are also seeing is that there is a little requirement in the NFPA code which talks about organizations are required to have a written inventory list of all the different types of sprinklers that you have in the organization, and that list is actually required to be posted at the box in which you put your sprinkler heads in. So the reason and the rationale behind that is to make sure that you know how many that you have, and then you have to have the minimum of 6, but then if you need additional ones, it's going to be based upon the total quantities that you have in your organization. So that's why that inventory list is going to be so important. All right, next slide, please. All right, so kind of, I'm sure a lot of you have never have experienced a survey from CIHQ. We take a lot of pride in our surveys, and all of us have come from the healthcare organizations, and we've been through surveys before, and we have that background and knowledge and understanding as to how that survey process works. From our facility standpoint, we actually require our facility specialists to be trained and certified under that HACP PE component. Well, and I apologize for the background. I am actually conducting a survey right now, and it looks like they've had a power outage, and I'm hoping the generator is going to kick on here pretty soon. So while you may not be able to see me, there we go. We're going to keep going and moving forward. So hopefully you can at least see me. So with that, we have recently developed this healthcare accreditation certified professional certification, and we have one specifically related to the physical environment. Our specialists are required to have it. It is open to the general public if they are ever interested in taking it. It is a certification around what all hospitals, safety, and facilities people really need to know outside of just life safety. So it's a great program. If you're ever interested, please take a look at that on our website. When we come in, we truly consider our survey as being a partnership with the hospitals. We do not come in with an overwhelming ego, and we truly believe in working with the hospitals. So we are not allowed to work for CIHQ if we have an ego. It's if you ever go out and look at feedback from the facilities that we survey, you're going to get the same feedback from everybody, is that it actually has been a very good experience. We don't typically ever get any negative feedbacks as we go around. Our survey process is done in a non-punitive way. We understand that life happens, things happen. We know that there are no such things as a perfect hospital. There are no such things as horrible hospitals. Hospitals are just on a journey, and we understand that. And so when we have findings, we like to work with the hospital, be a little consultative when we can, to try and help them be compliant. We know that they want to be compliant. We want to be compliant. So we will work through that and make sure that they are doing that. We provide a lot of resources to the hospital so they can have that available to them as well. It's a great survey process, and I hope you guys try to take a look at us in the future. Next slide, please. And that's all I have for now. So I look forward to any questions. Again, there's my contact information if anybody ever needs to reach out to me.
Billy, great job. And we're grateful and thank you for joining us today and offering your insights from CIHQ's perspective. So now we're going to turn our attention to Clint. Clint's going to walk us through the DNV survey process and updates and upcoming changes to the physical environment requirements. Clint, thank you for being part of the panel.
Thanks for having me, Mike. I'm glad we had the opportunity to talk with your folks from your people out there on the webinar. So next slide, please. Okay, so a few updates about DNV. So back in March, DNV GL changed its name to DNV. Most people refer to us as DNV anyway, but there was a name change. DNV back about 2013 purchased a company that I can't pronounce the name of, but we became DNV GL at that point in time. Recently, DNV has gone ahead and absorbed that company wholly. So we went ahead and changed the name back to DNV. For any of you that are accredited out there by DNV or certified by any of our programs, it does not make any difference of the name change. CMS is already aware of it, so it has no effect on any current contract or your certification documents or anything like that. Another thing is, during this unfortunate public health emergency for the past year and a half, 2 years almost, it seems, DNV is continuing to do its reaccreditation and accreditation surveys on site. So those are basically the every 3-year ones. Our annual surveys, DNV does conduct surveys every year. Those have been remote for most of the pandemic and will continue to be so through the end of the year. Looking at returning to fully on site for all surveys beginning in January of 2022. We did receive our psychiatric hospital deeming authority back in July of 2020. Not exactly new, over a year ago now, but a lot of people still aren't aware of that. And we do have a psychiatric hospital specific requirements. They're located in Appendix B of our accreditation manual, and they only apply to freestanding psychiatric hospitals. So if you have a psychiatric unit or behavioral health unit within your acute care hospital, the appendix doesn't apply. We will just continue to use the standard NIHO accreditation standards there. We're going to be updating our accreditation requirements this year. We hope to have these out by the early part of the first of the year, depending on the CMS review process. For those of you out there that may be DNV accredited, don't worry, you'll get plenty of notice about the changes in addition to what I'm giving here, and there'll be at least a 30-day implementation period. Next slide. So, talking about some of the proposed changes. So you're some of the first folks to publicly see our changes that are under development. Under PE1 facility, we're going to add some additional language that makes it more clear that physical environment management plans are required. They're generically covered under policies and procedures now, but some people were under the impression that they weren't necessarily needed. So we are going to make that clear. Also, with regard to our smoking policy, DNV has been, has always had in its standard that there's no smoking or tobacco use allowed in the buildings or on the hospital campuses. We did make an allowance a couple of years ago that under certain temporary situations, a smoking could be allowed on a patient-by-patient basis, along with a physician order. And this was usually related to behavioral health issues. But smoking could be allowed in very specific areas. We're clarifying that in our interpretive guidelines to make sure that it's very clear that that is for outdoor locations only. There will not be any allowed indoors. Also in our interpretive guidelines, we're moving our mandated timeframes. For testing fire alarm systems, for instance, we follow the NFPA 72 requirements for timeframes. Such as annual is once per year with a minimum of 9 months, maximum 15 months. We're moving that information to PE2 where it's more relevant. PE2 is our life safety management chapter. What we are putting into PE1 is that annual reviews of your management systems and your management plans have to be conducted within 3 months of the close of your annual cycle. So basically by the end of the first quarter after your annual cycle. Additionally, we are related to AEM programs for equipment. This isn't medical equipment, this is facility equipment. We're going to put the AEM requirements and the inventory and maintenance requirements into the interpretive guidelines under PE1. They're currently located in PE7, and some facility managers don't look in PE7 because so we need to make sure information is available for them. Next slide, please. Life safety management. For critical access hospitals, we're just moving the requirement for proper routine storage and disposal of trash to PE3. So we're moving it out of the life safety chapter and moving it to PE3. That'll be consistent with the acute care hospital requirement where it is at under PE3. And we're clarifying under SR9 for both the hospitals and the critical access hospitals that the requirement, and this comes straight from a COP requirement versus a life safety code requirement, is that patient rooms have outside door or window. Doesn't actually say patient sleeping rooms, it just says sleeping rooms in the standard right now. We're actually going to make sure we insert the word patient in there so it's clear that it's only for patient sleeping rooms, not your staff sleep rooms, other things like that. And in interpretive guidelines, we're just going to go ahead and make sure it's clear that the life safety code occupancy will be applied to all facilities, whether they're owned or leased by the organization, whether it's business occupancy. Basically, the appropriate life safety chapters will be applied. Also, life safety code drawings. DNV doesn't have a set requirement that you have a specific set of life safety code drawings that show certain things, but basically we're going to put in that they are still needed to show compliance with your with the life safety code. And this can be the original this could be the as-built drawings, it could be professionally produced drawings, it could be drawings produced in-house, but we still have to have some source of baseline information to show that shows compliance with the life safety code. And we're also going to go ahead and add some language regarding the NFPA 99 requirements around operating room, fire safety training, and fire exit drills. Next, please. Under PE3, safety management, we're adding the word facilities to the periodic surveillance requirements. It's already in the critical access hospital requirements. This basically deals with the environmental rounds or the safety rounds that you do throughout the hospital. One thing you notice, it does say periodic surveillance. There isn't a requirement in DNV that you do this twice a year in clinical areas and once a year in business areas. It's up to the facility gets to design its process on how often it conducts this surveillance with facilities and grounds. And we also already talked about the movement of the trash and the trash storage and disposal from the PE1 to SR8. Next, please. Security management. I'm going to go ahead and clarify for the hospitals that that your workplace violence control prevention program must meet at least the requirements of the OSHA 3148 publication on the guidelines preventing workplace violence for healthcare and social workers. It's always been referenced in there. We're just changing the language a little bit more to make sure it's clear that it needs to be done. We'll be adding some language to the interpretive guidelines to help with that also. In the critical access hospitals, we're going to actually require that critical access hospitals also follow that same process with the OSHA publication. Currently, it is just in the interpretive guidelines for critical access hospitals. We're going to add some in the interpretive guidelines also. We're going to add guidance that the SVA also has to address cybersecurity risks. Still, it's up to the hospital to determine what those risks are and how to do it. But it is something that's becoming more and more of an issue. We saw this summer multiple issues regarding cybersecurity throughout the country, and that did cause problems. Next, please. Our hazardous materials management system. We have a chapter with no changes, no real changes. Under PE6, our emergency management system, no changes to the standard. They're already basically sitting there stating what the COP needs to do and that you have to follow NFPA 99 chapter 12 per our adoption of that. But what we are going to do is update the interpretive guidelines. CMS this spring issued Appendix Z of the State Operations Manual, about 150 pages worth of good information. We're going to put some of that into our interpretive guidelines to assist hospitals. Next, please. Under PE7, no changes to the standard. And as I mentioned when we talked about PE1, we're going to be taking the facility equipment requirements and moving them out of the medical equipment chapter. So there is less confusion. It'll also facilitate, make the interpretive guidelines flow a little bit better in PE7. PE8 utility management system. We are adding a new requirement for water management program. We've heard that theme before from some other AOs. Our requirement is going to be that we have one, and the IG interpretive guidelines is going to, we're going to have information to support it, such as complying with the CDC toolkit and ASHE 188. Next slide. One last thing is all of our chapters are going to go ahead and have the interpretive guidelines cleaned up, removing redundant and unnecessary language. So those won't be changes that really affect anything. They will just make them easier to read and that. And then we'll do spelling and grammar corrections throughout. So I want to thank you for your time on that. And at this point in time, Mike, thank you for everything.
No, absolutely. And Clint, one, grateful for you being a part of the panel today and a great update from the DNV perspective. So some of the feedback that we get is we want to make sure that we allocate enough time for everyone to compile their thoughts and to ask their questions in the Q&A. So what we're going to do is going to be back with you in about 2 minutes so that you can get your questions into the queue. We already have a couple there, and we'll be right back with the Q&A.
Hi, everyone. This is Grady with Soleran. I just wanted to pop in and say thanks so much for attending today's webinar, and I wanted to briefly introduce you to Soleran and ICM. Soleran has been developing software solutions since 2004. We've dedicated ourselves to developing an intuitive set of solutions specifically for healthcare facilities. We've also developed the market's only true ICM platform. ICM stands for Integrated Compliance Management. So what is integrated compliance management? Well, ICMs are generally comprised of multiple solutions designed to work seamlessly together within one platform. There's literally hundreds of systems and processes across multiple departments used to manage healthcare facilities. ICM is simply taking all of those solutions across all departments and putting them into one integrated platform. Having all your data in one place allows the system to automate many of your daily tasks, gaining better visibility, trending, and analytics. It actually does work for you. Soleran's ICM consists of 6 individual suites that include work orders, rounding, permitting, vendor management, project management, and security management. Each ICM suite consists of 4 to 8 different applications that can be used individually, but you'll see the most benefit when it's used as part of the entire suite. Of course, ICM's unique advantage is using multiple suites across the entire platform. Bringing this information together in one place across all departments gives you better visibility than what you've ever been able to achieve before across the entire hospital or even across the entire healthcare system. When your data starts working together across an ICM platform, you'll be able to visualize your data using new tools like the Compliance Survey Dashboard or the fully integrated Life Safety Drawing Manager. I know I went through this really quick and at a really high level, but we just wanted to introduce you to Soleran, ICM, and the tools that will ensure you're ready for your next survey. If you'd like to learn more, contact us at soleran.com. Manage your facility better. Mike, back to you.
That's fantastic, and I appreciate that. So we had a chance to take a little bit of a break. We have a few questions in the queue, and it's not too late to get your questions in there. There's been a lot of changes coming in the environment, and especially through the end of the year. So this is a great time to get some clarity from all 3 of our panelists. And before we jump into the Q&A, I would be remiss if I just didn't thank Jill Allen and Jacob Warnicki. They work tirelessly behind the scenes to make sure that these are even possible. So grateful for the both of you to be able to orchestrate behind the scenes to allow us the venue to be able to have these webinars. Thanks to both of them for that. So let's do this. Let's jump into the first question. So Lance, I'm going to throw this one out to you. You mentioned cybersecurity. This has been brought up a lot at the different state ASHE conferences. So as an addition to the EM standards in 2022, do you have a specific area related to cybersecurity there is a focus on?
Yeah, and Clint talked about this as well, and so did Billy, and feel free to jump in as well, both of you. I know one area for sure that they're looking at right now is specifically in regards to ransomware. There's been multiple issues that's happened within hospitals where hospitals have been a victim of ransomware. I know specifically one hospital down south that had their exit strategy was they went ahead and actually paid the ransomware to be able to get their information back because they felt that was less damaging than releasing the information, obviously, but it was a hefty sum for them. Obviously, the government gets involved, tries to help with that, but it's been happening in multiple areas. And for example, in one area that Soleran combats this with our software programs is multiple areas of backup. There's multiple areas all throughout the nation that we use for backup for programs. That is an area that hospital ITs divisions are starting to focus on as well. They're realizing that they need to go further. So, specifically with ransomware, with your backups, really start working with your vendors that, and see what other options that they can do to expand.
Good. And I'll throw it out to the rest of the panel. Is there any other insights that anybody had on that topic at all that you wanted to share?
From DNV's perspective, we work closely aligned with the COPs also, and
Mhm.
CMS has been asking questions about this and what the accredited organizations have been doing. Our approach, it's always been included as part of emergency management. We're basically bringing it more to the forefront so that it's more clear to the hospitals that they need to have a program. We're going to explore that program based on the hospital's policies, and that we're going to basically ask them, what are your policies? What are your process? And we're going to deeper explore that. It's going to bring the IT folks into security management and emergency management a little more. And they are an integral part of that. The physical security and the electronic security is, run hand in hand together.
Right. No, I appreciate that, and great
And I
clarity
agree.
there. There's just a lot on the cybersecurity front. Do you have another comment? And if anybody else, okay.
Yeah, I was just going to say I agree as well. And one of the things we look at as well is obviously, just like everybody else does, taking a look at that HVA or hazard vulnerability analysis, just to make sure that you're at least looking at it and addressing it. So you can take some precautions to put into place if you definitely do feel like you have a vulnerability within your system. And just asking, hey, have you ever considered to do either at the least try to do a tabletop exercise on it?
Right. All right. No, that's great insight, and I greatly appreciate it. Let's go on. I have another question, and Billy, I think that you're the only one that can answer this question. So a question came in and says, I'm interested in hearing more about CIHQ's philosophy in approaching surveys as a partner. Can you provide more information regarding that process?
Absolutely, I'd be happy to. So we truly partner up with the organization. So it's easy for accrediting organizations to come in, look at your hospital, tell you what you're doing wrong, and then just leave and walk out, and you never hear from them again for 3 years, or if you have a complaint or something like that. And that's not what our philosophy is. We truly come in and we want to help you through your journey. Like I said, there are no such things as perfect hospitals. There's no such things as horrible hospitals.
Mm-hmm.
It's just a journey. And we work with you and partner with you in that journey. So we want to always be available for you. We provide as much consultation as we can and are permitted to during the survey process. It's easy to go in and tell you, okay, you're doing this wrong, but they never provide you any type of guidance as to how to get there and what resources you have available even outside of us. So that's what we mean by the partnership.
No, and I appreciate that. And I agree, there's not good hospitals, there's not bad hospitals, but every now and then the lights do go out. And,
Right.
Just where you are, and I half expected to see a ghost in the background, Billy, not going to lie, this close to Halloween, but
Right.
grateful for the insights
Exactly.
on that one. So we do have a question, and I'll start with Clint, but everyone chime in as well. There's been some confusion regarding battery operated lights. This is, and I've seen this come up we've got about 4 or 5 of the state ASHE conventions. This has come up at every single one of those conventions. And so there is confusion regarding these battery operated lights installed in anesthesia rooms, for example, in the ORs. Can you guys provide some clarity about the standard and how they can meet it correctly?
Okay. So DNV, we have in our standard a requirement that basically, and it's straight from NFPA 99, that requires you to have battery powered lighting units in anesthetizing and areas doing deep sedation. And we've gone ahead and expanded that to existing hospitals also. It really was a requirement even during from the 1999 edition of NFPA 99. So the requirement's actually been out there for quite a while. It wasn't really anything new with the 2012 edition. But anyway, some hospitals still get confused over it. And one of the areas of confusion comes from different definitions of deep sedation. General anesthesia is usually pretty clear. They're using anesthesia machines. It's in the ORs usually. But the deep sedation is the question. And so one of the things that we've been trying to, when we see this situation and in our training programs, is to make sure that the clinicians and the facilities folks are on the same page. And the clinicians are aware that for at least the purposes of the design and use of these rooms, they do have to refer to the NFPA 99 definitions of deep sedation. That really helps a lot. Just because it's MAC, monitored anesthesia care, doesn't necessarily mean deep sedation. So it works both ways. They could go overboard and put lights where they don't need them. The last thing is, in an emergency, somebody could have deep sedation anywhere, in an emergency. We're really looking at this and from a practical point of view, applying it to areas where deep sedation is planned.
Right.
If they have to go into a room, do an emergency cut down on somebody and they deeply sedate them, that's an emergent situation, and sort of falls outside of that. And also lastly is the cooperation. We've walked into an MRI and found an MRI safe anesthesia machine. Nobody knew they're doing anesthesia in there. So again, clinicians need to communicate well with what that is. And that presented a couple problems. We now have an anesthetizing location that wasn't followed, wasn't designated by the governing body necessarily. We may or may not have proper ventilation for that anesthesia machine in there. So are we exposing folks unnecessarily? So there's a lot of complications. So it's part of that, making sure that clinicians and the facilities guys are our team in this.
Yeah, absolutely. And did anybody else have a comment on that from their perspective?
No, I agree with Clint completely. So, yeah, I don't have any other feedback. I'm on board with exactly what he said, and that's exactly how we look at it as well.
Good. So one more question came in, and we still have a few more minutes left. If anyone has a question, you can throw it into the Q&A. We'll do our best to get it answered. But Clint, this one is specifically thrown out to you, but others might be able to chime in as well. But it says, for DNV, can you talk about how to align annual review of the management plans with annual report presentations that may occur on a rolling calendar throughout the year as data or risks are identified?
Well, basically, it'd be great if everything could just run on a calendar year, of course, January through December, and make things a lot easier, but we know that doesn't happen. And we know there's different reporting things. You can have one management system report out, they can be on different annual cycles if that's the way your process wants to be. It's a coordination of the activities and how you present it. Most of the things read as at least an annual review. You could actually do it more often. Of course, obviously, sometimes you want to have enough data to be able to accurately review and analyze the data. If you do too short of a review period, you're not going to have data to come up with real conclusions on. But the hospital, can present it and come with its own methods as long as it's done on at least a 12-month or annual basis.
Perfect. And we're right at the top of the hour. So that's going to end today's topic. I want to personally just thank Lance and Billy and Clint for their time. You guys have been a huge resource and valuable information that we've all benefited from. And I greatly appreciate all three of you being with us today. Just a couple of reminders. One, everyone's going to receive an email with a link to future webinars. We're going to be having another spring webinar series. So there's going to be more information coming out about that. So we're really excited about what that's going to look like this spring. But number two, if you found this helpful, we just encourage everyone to share the information with their colleagues so that we can grow this community. We really feel that we get better together. And so as we grow the community, the knowledge pool also grows and we grow together. So share it with your colleagues. And so in closing, if you go to Soleran.com, and up at the upper right-hand corner, there's a little link that says Ask a Compliance Expert link. It's at the top. There you can engage with our FCTT experts and watch our other webinar recordings for great tips. And just as FYI, there's a couple there that have ASHE Cs attached to them. So you can engage our experts there by joining the facility compliance think tank group on LinkedIn as well. So there's just a lot of ways for you to get connected to those folks. And if you're interested in more information about any of the products that we presented during the video or at the beginning of the presentation, reach out to us by scanning the QR code that's here. We're going to be happy to chat and just discuss whatever the needs are. So finally, this does conclude today's webinar. Soleran and our speakers would like to thank you for joining us, and we look forward to seeing you all in the spring. Have an awesome rest of your day.